Now, our next speaker is Dr. Rajib Neupane. He's from United Mission Hospital, Tansen. He will be talking the difference palliative care makes in a rural hospital. So in his introduction, he's a consultant physician and chief of the clinical service, general medicine rehab at United Mission Hospital in Tansen, Nepal. He's a medical consultant in Pratibha Samuha for HIV patient, and he's the chairman of the National Doctors Association Nepal, Palpa district branch. Please, Dr. Rajib.
Kind introduction, and I'm presenting on mainly based on my own experience that I gather from practicing by palliative care, integrating with my general regular practice at our hospital. So this presentation is not about data and quantitative things, rather experience that I and my team gather from our hospital. Topic of my presentation is the difference palliative care makes in rural hospital of Nepal. So let me begin with the introduction of my hospital. I worked in a United Mission Hospital that has been started since 1954, which is under Medical and Development Trust, UMN. It is a project that has started with the values of love and service, equity and social justice, integrity, innovation, creativity, special concern for poor and marginalized people, care for the environment. And the mission has been inspired by God's love, especially to care and give special focus on poor and marginalized group. It is worth to mention that we recently celebrated our 70th anniversary. So we do have a lot of a variety of department, including high dependency unit for adult and newborn with rehab ward. As you can see in the statistics, our hospital is almost 70% bed occupancy throughout the year, and Lumini provincial government has approved for 200 facility bedded hospital from the coming years. And our hospital provides free care for economically compromised patient if required. So with such a busy hospital, it is fair to assume that the hospital has gained its reputation and trust among the trusted institution among the people. We have patients they are coming from Lumini province, Gandaki province, and even the northern part of India. But because we are located in the hilly region, the patients have their own difficulties and struggle to reach there and to continue care. For example, society of older generation is, I think, resonate all over Nepal. And these people have multiple comorbidities, poor and deteriorating health with increased dependency on others and unplanned admissions. Being in a hilly region, they have difficulty with the travel modes, especially because of the roads. And sometimes it is very costly, especially if they need to reserve a taxi. And there is a caregiver problem if the person need to be admitted and if they need a longer, especially if they need to stay there in the hospital for a long period of time. And hospital provide, in the last year, we provide almost 30 million rupees of free care to the patient, and 20% of free beds have been given to patient per day. So that shows society is still very economically poor. So with this background, you probably have an idea. It is very difficult for the patient, as well as it is very difficult for healthcare professionals to provide and make decisions for these people with incurable conditions. When you work in a resource-limited setting, busy hospital, no hospice service to send them to nearby, and sending them home means no further contact with them and probably no follow-up. So with such, in such time, we came in touch with the Sunita project that has bring us with the training and toolkit with SPICT LIS approach that especially help us to recognize these palliative care candidate earlier And with the SPICT LIS approach, we started to make shared decision among the team. The team is formed by doctor, nurses, rehab group, and patient relative and family members. Sunita project help us with the clinical training as well as eco online session to discuss about difficult cases. We started to fix ceiling of treatment after discussing with the friends and families of the patient. And we, as much possible, we try to make advanced care planning for them. And confidently, we are providing the best available treatment for the patient. And if required, sometimes we refer case to Green Pasture Hospital, Pokhara. So I would like to mention the few practice change after introduction of SPICT LIS in our hospital. We decreased the number of referrals to other hospital, mainly because we are doing evidence-based referrals for if they have prognosis and if there is extra management possibility in other hospital. Most of the time, as a general hospital, we are able to provide. And we discourage unnecessary investigation and futile treatment. We provide disease knowledge about the disease to patient and family members and help to communicate them with each other. That has significant impact in their lives. So how we do this? We try to, for each chronic illness, major disability, or frail and elderly patient, we try to discuss the things among the family members, doctors, nursing and rehab team with social service department that is actively involved with financial support and spiritual care. So after doing holistic assessment for this patient, we try to do for the management, and it is useful in various departments. For example, in high dependency unit, we fix ceiling of treatment not to intubate or DNR while we admit or soon after admission. From the general medical ward, we try to make advanced care planning for the patient before discharge. And from rehab department, sometimes we do home visit and try to do supportive measures that they can use at home. So integrating palliative approach in our regular practice along with specific disease-directed therapy has its own impact. And surprisingly, it has a protective effect on hospitals' busy schedule because we are not doing unnecessary labs, we are not doing unnecessary follow-ups. So surprisingly, it is very beneficial for a busy hospital like ours. And it decreases financial burden of the family and patients. Of course, the patient can have peaceful, comfortable end of life, mostly being together with their families, friends, and relatives. We do have some challenges, notably most of the hospital have the similar thing. I think transfer of trained staff. We have various cases like chronic disease and lung, kidney, liver, and so forth. Sometimes we do get metastatic cancer disease referred back from tertiary cancer hospital for palliative care. So why it matters more to incorporate palliative care in general practice based on our experience. Actually, the primary point of care is general hospital. So being a de facto primary point of care, it is more easy for the patient and family members to be involved in such hospitals and make advanced planning for them. It is easier to make holistic assessment, and it saves patient money, address their desire, and support families' concern if we can incorporate in our regular practice. So in our hospital, we are trying to work up on a possibility to develop dedicated palliative planning group so that the team could have enough time to spend with families of the patient, and they can make a better advanced care planning for them. I want to conclude my presentation by saying providing palliative care is affordable by integrating SPICT LIS approach in general hospital. It is cost effective and sustainable and easier for the patient. Palliative care is a right of Nepalese citizens despite of their financial status and location, and it is a practical approach in rural context of Nepal. And having shared decision with doctors, nurses, and patient and their families, and make one decision for the plan is acceptable in Nepalese society when you have a half percentage of the people are either out of the town or out of the country. So it is a very practical approach. And I'd like to end my presentation saying thanks to Dr. Rachel, Dr. Tulbadur Pun from our hospital, and Dr. Dan and Dr. Amrita from Green Pasture. Thank you.
Thank you, Dr. Rajib. Excellent, completing within a given time period of 15 minutes. Thanks. If we have any question special, maybe one question, or we will go ahead if there is nothing special. I think you are gone through, no questions, everything is clear.